Very good afternoon to all of you, and I thank the chairperson for those excellent words. And we have heard from my previous speaker, Dr. Ajay Kumar, that definitely there is no doubt that GLP-1 analogs are a pharmacotherapy that has a lot of benefits. But why then, though they have been in the market, have they not picked up as much as we should have? Possibly it is because of the multitude of injections. So now, over the next 20 minutes, I'm going to look at data which looks at once a week GLP-1 analog and see what benefit they have over the conventional therapies that we have in GLP-1. Okay, so this is my disclosure pertaining to this particular topic. So now, we have heard about the beneficial effects of GLP-1. Let me reiterate them in a manner that it is understandable to everybody. It increases insulin secretion, basically looking at all the pathophysiologies that could help in management of hyperglycemia and how GLP-1 analogs help in it. It increases insulin secretion to maintain glucose homeostasis, decreases glucagon secretion, and thereby decreases both the fasting, postprandial, and the average of the two, which is the HbA1c. Apart from that, it also looks at the gastric emptying time, which is very crucial for the blood glucose control, especially the postprandial hyperglycemia. This, we have only one molecule which is very good, which is the AGI, and this is another such molecule which seems to have an important role in decreased gastric emptying time. It increases satiety due to delayed gastric emptying, which is very important for diabetic patients because most of them are obese and they're not able to stop eating. It decreases food ingestions due to effects on the brain. It acts at the level of the hypothalamus to cause satiety also. And most importantly, all of us are told if you're a good doctor, you should prevent beta cell exhaustion. So here is a molecule which increases beta cell number and increases beta cell mass. We have seen this as animal studies and we have indirect evidence in humans also. So now let's look at the available GLP-1 receptor analogs that are available and looking at the half-life and what do they have, which pertaining to each of these molecules. We have dulaglutide, or rather we will be having soon. Most of these molecules we are going to have in the next couple of months. So it's important that all of us sitting in this hall understand how they work and how we should use them. So we have dulaglutide, which has a half-life of about 4.7 days, which has to be used once weekly. And you have albiglutide, which has a half-life of 5 days. And then we have the lixisenatide, which has a half-life of 3 hours, and once a week of exenatide, which also has a steady state over 7 weeks. We have liraglutide with a half-life of 13 hours, and a twice-a-day exenatide of 2.4 hours. So depending on the half-life, it depends on when we have to dose them. So let me stick to only the once-a-week dosing because that's our area of interest. Now, what does dulaglutide have? It has a pre-attached needle. Many of us know that quite a large percentage of our patients have a needle phobia. The minute they look at a needle, they say, oh no, doctor, this is something I don't want to use. So this has a pre-attached needle, which is actually not visible if one has seen this pen. And there is no need to reconstitute. That's another thing which patients are very worried about. How can I do it? It is very cumbersome. Do I need to go to a doctor? How will I learn about it? Because for us, something which seems so simple is to the lay person who comes to you quite difficult, and we don't have that much time to explain, and they will make mistakes. So here is something which you don't need to reconstitute. It has a pre-filled pen and it automatically injects, and it's a single dose once a week, so it's very, very easy. We have also albiglutide, which again will soon be in the market. Again comes in a pre-filled pen and a single dose, but it is not pre-filled or it is no pre-attached needle. And I'll talk about exenatide once weekly, which again comes with a pre-filled pen and a single dose. So the advantage of dulaglutide is that it is going to have a pre-attached needle. You don't need to reconstitute, and the patient does not even need to see the needle, so that the needle fear is gone away. So now let's look at what the long-acting and the short-acting GLP-1 analogs have differences between the two when we are talking about glycemia. Let's look at the effect of the short-acting on fasting blood glucose level. The short-acting ones have a modest reduction, but the long-acting ones like the once-a-week exenatide, liraglutide, which is once a day, albiglutide, and once-a-week dulaglutide have strong reduction. There are a lot of data which supports these claims. The postprandial, however, the short-acting have a strong reduction, while the long-acting has a modest reduction. So as far as fasting blood glucose goes, the long-acting reduces them very well, but in the postprandial, it is modest. And as far as fasting insulin secretion is concerned, there's a modest stimulation with the short-acting and a strong stimulation with the long-acting GLP-1 analogs. And the postprandial insulin secretion is reduced with the short-acting, while there's actually a modest stimulation with the long-acting GLP-1 analogs. Then the other part which does not look at insulin is the glucagon secretion, which today we know is a very important part of hyperglycemic control without causing hypoglycemia. So what happens? In the short-acting and the long-acting, there's a reasonable good reduction of glucagon secretion, and in gastric emptying time, there is a decrease in the short-acting and a modest decrease in the long-acting one. And both of them, the short and the long-acting GLP-1 analogs, there's a reduced caloric content. There's a body weight reduction of about 1 to 5 kg in the short-acting one, while in the long-acting GLP-1s, there's a reduction of about 2 to 5 kgs, which is very, very good considering all of us who have tried to lose weight. It's so difficult to lose even half a kg. So something which can reduce something like 5 kgs is something to look forward to our diabetic patients. And then induction of nausea, about 20 to 50% in short-acting, and Dr. Ajay has already alluded that the long-acting actually has less side effect of nausea, and roughly about 20 to 40% have it. But however, the advantage of this is that it attenuates very quickly, and roughly about in a month's time, they should be quite comfortable. In fact, I've also done work on this molecule, and in our patients, we are very happy to see that they didn't come with any major nausea, vomiting problems. Now, if you look at how the blood, the levels or the serum levels will be plasma levels of GLP-1, if the short-acting or long-acting, possibly this is how we are going to look at. The short-acting, if you're giving twice a day, would have a peak and come down, and again have a peak and come down. If you're giving a long-acting, it's going to stay sustained through the day. Now, if you look at the blood glucose levels, so this is how it is going to be with the short-acting in red and the long-acting in blue. So they're going to reduce the fasting and the postprandial. And if you look at the effect, roughly seems to be the same, but this is how it will look in the blood. Now, this is a slide which has already been alluded to, but let me go through it because I feel it's very important, again, to differentiate between the short and the long-acting and to understand how this works. The final function of the short-acting, this is short-acting, this is long-acting, is it decreases appetite, increases nausea, thereby decreasing gastric motility, decreasing glucagon and decreasing insulin, decreasing transpyloric flow here, and decreasing intestinal glucose absorption. And when we look at the long-acting, so long-acting GLP-1, they have the effects are roughly the same of increasing appetite, but the nausea, if you see, has a smaller arrow, so it's less, and the gastric motility is also reduced a little less, but the insulin increase is much more, and the glucagon decrease is also much more. So decreased effect on gastric motility in the long term, and less pronounced effect on the PPG. So basically, when you're looking at it clinically, this is what you're going to see, that the fasting will be much better reduced, while the postprandial will be shade less reduced than the short-acting. So now coming back to what do we need to know with all this, we need to know patient needs. Do they need this once a week GLP-1 receptor agonist in the treatment of type 2 diabetes? So why do they need it? Because it is similar to human GLP-1, and we know GLP-1 gets destroyed very quickly, and that is why we had DPP-4. So if we can give a GLP-1 instead of preventing destruction, it would be good, and this is very similar to the human one. And it is smartly structured, as you have heard in the previous talk about the glucose association, dissociation, so there's no hypoglycemia. There's a long duration of action, and the rapid onset of action also, though the duration is long, it starts working quickly, as I will show you in some more slides. It decreases the postprandial and the fasting, being shaded better on the fasting, and it can be used in many populations, even in special populations, including renal impairment. And this is something which we are all very worried about, especially if you have to change the doses and whether we can give to many of our population of patients. They just go away and they don't come back, and you never realize whether they've gone into renal failure, and that's our concern. And then it's a single dosing regimen which is very comfortable for the patient, and then it is simple and ready to use device. So I think the audience will agree that this kind of GLP-1 is something that we all are looking forward to use in our patient, because we are short of drugs. How many of us can claim that all our patients are at 6.5 and 7? And if they are not, why are they not? Possibly we don't have enough modalities for treatment. And here is a new modality, though an injectable, just once a week. So we are patient-friendly in that aspect. So who should we use? Patient not achieving HbA1c targets, has issues with adherence. Doc, do I have to take it every day? No, you take it once a week, maybe on a Sunday. No hypoglycemia. I think that's a huge, huge advantage. And the second huge advantage, which are usually the unmet needs, is weight loss. So all these considerations are important for us. Now, let's go back a little bit again at the pathophysiology. All of us know about first phase insulin and second phase insulin. We all know that in diabetic patients, they are less. So if you can see this is the first phase insulin and second phase insulin, first phase and the second phase in healthy subjects. And this is the first and the second phase insulin in diabetic patients. So this is the diabetic, and both these patients were given GLP-1. So you can see that what happens to GLP-1 in the healthy subjects, both the first phase and the second phase was retained but stimulated. But look at here in diabetic patients, there's hardly any first phase or the second phase insulin response. It's all gone down almost to negligible values. And if you give this Trulicity or dulaglutide, you find that it actually goes back almost to normal levels, maintaining the first phase and the second phase of insulin. So this is something which actually really excited me to know that here's one molecule which actually brings back your first phase and second phase insulin back to where it should be. So now, little bit about the studies that have been done with dulaglutide. This was the HbA1c reduction. This was the award 6, which compared, this was the non-inferiority study with liraglutide. So till now, none of the other GLP-1 have been able to prove a non-inferiority. This was the first time that this dulaglutide was able to establish a non-inferiority with this molecule compared to liraglutide. Both of them had roughly about 1.4% reduction in the HbA1c. And these are some of the studies which have looked at different molecules. This is metformin, award 5, award 1 is with metformin and pioglitazone, and in award 2, it is metformin with sulfonylurea. All of these had roughly around 1,000 patient population, well-matched, randomized, placebo-controlled trials. And if you can see the HbA1c reduction with sitagliptin, it was significantly more with dulaglutide. And with exenatide, whether it was 0.75 or the 1.5, it did better than exenatide. And the last one, which is award 2, which looked at metformin, there was a significant decrease in the HbA1c compared to metformin. So now this study looked at albuglutide. I'm just trying to cover all the long-acting. This was albuglutide, which looked at insulin glargine. In this study, the insulin glargine fared a shade better in HbA1c control. HbA1c was better controlled than albuglutide, but it was not significantly different. Now, this is compared duration 2, which I was also part of, which looked at once-a-week exenatide with DPP-4 inhibitors. And if you look at this exenatide once a week, which is in blue, compared to sitagliptin or pioglitazone, it had a significantly more change in HbA1c when the group of patients had at baseline less than 9%, or the baseline was more than 9%. So irrespective of what is your baseline HbA1c, the HbA1c reduction in the group with dulaglutide, or rather once a week exenatide, was definitely better. So now we are going to look at some data on what is the once weekly effect on the postprandial and fasting. I have already told you that the fasting is better, but we need evidence, so this is the evidence. So this is where dulaglutide was compared with twice-a-day exenatide. This was the Award 1 study where this is baseline. They were well matched for their HbA1c. All of them, when they did their 7-point blood glucose over a single day and they matched over time, they almost all of them, whether they were on dulaglutide, exenatide or placebo, showed a similar baseline HbA1c. But what happened when you gave a placebo, there was not too much of a decrease. This is dulaglutide, the HbA1c reduced, and the fasting and the postprandial also reduced. And when you gave exenatide, you can see here that the postprandials reduced much better compared to the fasting, compared to dulaglutide. So the postprandial control with exenatide twice a day was better. This is the Award 1 study, which looked at onset of action. So you can see that though this is long acting, it starts working almost immediately. Within the first 2 weeks of injecting, within the first 2 weeks it has started working, and the action is very quick. And it reaches a sort of a plateau. And within 2 weeks, the level of fasting blood glucose comes down. So you know, after you give the injection, within 2 weeks you can test and you know whether patient is responding or not. This is very important for patient satisfaction. So when patient sees his blood glucose is coming down, he is happy that he is on the right track. So now we look at once a week looking at patients achieving targets. Now this is a proportion who achieved less than 7% as endpoint versus glargine, and patients in Award 2 with metformin and sulfonylurea, and this is with lispro and metformin, and this was Award 3, which was with metformin. And we find that whether it is dulaglutide 1.5 or 0.75, more number of patients reached a target of 7%, treat to target at 7% with any of the comparators, whether it was glargine or metformin. And if you looked at 6.5, because the ACE recommends 6.5 HbA1c, here also in the Award 2, Award 4 and the Award 3 studies, more number of patients reached the goal of 6.5 with dulaglutide of 1.5 milligrams, which is in blue. So now we look at another major problem that all of us face in treating our patients, which is weight reduction. And we have the study, which was again Award 2, 4 and 3, which looked at, as a comparator was glargine, and they looked at what happened to weight. If you can see, with dulaglutide 1.5, the weight had reduced by about 1.87, and with 7.75, it was about 1.3, and there's a weight gain with insulin, which is acceptable. All of us know when you give insulin, though it is the least with long-acting insulins like glargine, even they had a weight increase of 1.4. So if you actually look at this 1.4 and 1.3, almost getting something like 2.7 weight reduction. And this was comparing again with insulin lispro and metformin, and they found that there was a reduction of weight in the dulaglutide arm. And this is with metformin, which again showed there was a reduction of about 2.29 kgs with the dulaglutide, which was 1.5 milligrams. So this is once a week GLP-1 and how do you administer it. So this is the advantage of it, that you have liraglutide, exenatide, albuglutide and dulaglutide. So dosing frequency of exenatide long-acting is once weekly, anytime during the day. All the three, once a week is anytime during the day. And ease of administration, this requires a kit with a 23-gauge assembly needle. This albuglutide has a pre-filled pen with a 29-gauge needle. However, you have to wait for 15 minutes for the 30 milligrams pen and 30 minutes for the 50 milligram pen to ensure the reconstituted solution is mixed. While in dulaglutide, it is pre-filled auto-injector device, and the sites are usually the same sites which we use for insulin administration. So, coming to almost the end of my talk, scanning the horizon for durability of once-a-week GLP-1s. The long-term glycemic control is important. Some of the data has been shown by Dr. Ajay Kumar, who has seen that there is, for 72 weeks also, there was no change in the HbA1c. So this is very important. Apart from glycemic variability, the long-term control is the one which has metabolic memory to prevent complications, both micro and macrovascular complications. There are big trials like the AWARD, HARMONY, and LEAD. LEAD was with liraglutide and AWARD is with dulaglutide, which shows that once-a-week GLP-1 receptor agonists are effective and well tolerated across the continuum of care with type 2 diabetes. However, like he also mentioned, we are waiting for the long-term CV outcome data to understand whether they are not just not useful, not beneficial, but whether they can be beneficial for the heart. We are looking at positive results for the cardiovascular system, especially the blood pressure and the ejection fraction, whether they improve that and could have a special place in cardiovascular patients also. So thank you very much for a patient hearing.